Happy Thursday night. Hello, everybody. Thank you for being here. We have Dr. Martin Rosen with us today. Welcome, Dr. Martin.
Hi, thank you for having me. I appreciate it. It's nice to
We
meet
are,
you.
thank you. Nice meeting you too. We love learning from chiropractors. So we're super excited that you guys are here. We believe in collaboration, in working together. So in
Absolutely.
order for us to better treat our patients, it's so important for us to talk to other professionals because they see things that we do not see.
Hmm.
And this is what Area Circle is all about, not only multidisciplinary, but interdisciplinary care. I'm going to go ahead, guys, and introduce our speaker. After that, he's going to start his presentation. Please, if you have any questions, put them in the chat box. If you're an Area Circle member, you get to see most of these early. We record some of these on Fridays. So you guys get to watch them early and you have immediate access to them inside our membership portal. So reach out to us if you would like to be part of our membership. So here we go. Dr. Martin Rosen, an internationally recognized chiropractor, educator, and clinical innovator with over 4 decades of experience in pediatric, cranial, and neurologically based chiropractic care. A leading authority in Sacro Occipital Technique, SOT, he is known for integrating spinal mechanics, cranial motion, dural relationships, and neurological indicators into precise low-force clinical systems. He has trained thousands of practitioners worldwide through postgraduate and hands-on certification programs focused on infants, children, pregnancy, TMJ, and complex neurological cases. As an author and curriculum developer, Dr. Rosen is committed to advancing clinical excellence and mentoring the next generation of chiropractors. Our topic is the critical role of cranial and postural growth patterns in early life, the development, affects, and function. Welcome to the Area Circle stage. The floor is yours. You're welcome to share
Thank you
your
very
screen.
much. I appreciate it. So what I'm going to try and do today is I have a presentation that is going to be different, several layers. And parts of it, again, knowing that you're all professionals, I might push through a little bit faster, but I really want to just bring home the idea of how important what we both do, what we all do, is to general development and potential especially in children. That's what I work with. And of course, airway development is very prominent in that particular point in time. So some of it may be fast, some of it may be slow, but you'll have it to be able to look at and go through it again. But I just hope to be able to add some knowledge here as a base, because as we just talked about a minute ago before we started, how important it really is for co-treatment models. I mean, none of us stand alone here, especially when we're dealing with developmental protocols. And it's really great to be able to talk and communicate with each other. So that's kind of what the purpose of this program is, to give you an understanding of what we as chiropractors do, and then to kind of look at how we can fit into the paradigm of what you guys are doing out there, especially because it's so important topic. So
Yes.
with that said, I don't have to tell you about me because you did a great job telling you all about me. But what I really want to talk about is brain development. Okay, so we understand that at birth we're born with all the raw materials we need to adapt and learn from environment. And as things go on, we become more specialized. The survival areas mature, things move on. And so what we're really trying to do here is get an idea of how important the process is in the beginning. So with brain cells, we know that 90% of them develop in that first year to 2 years of life. There is a huge synaptic development occurring. In other words, 1,000 to 100,000 synapses are formed. Again, the peak potential of that synaptic development is around 8 months, but it does grow very fast for the first 2 years of life. So everything that impacts the cranium, growth centers, neurological integration, that first 2 years really sets up the foundation. So if you see here, this is the peak synaptic development period at around 8 months, which our brain is then forming so many communications and laying down the foundation literally for the rest of our lives. And those first 2 years is probably the most dynamic and important phase of postnatal development in human beings. As I said, the brain reaches 80 to 90% of the volume at that period of time. Also, things like cognitive development, motor development, emotional development, neurodevelopmental challenges and issues can be laid down in that first period of time. So we talk about, two things the brain needs a lot of is oxygen and, of course, glucose, sugar. And, of course, when we talk about airway development, it's about the ability of the brain to get oxygenated, whether it be during the day or at sleep. But we'll talk more about that as we go on. The other piece that's so important is this little factor here. The cerebellum, which is our mainframe computer, grows about 240% in the first year of life. And that area has the reciprocal projections to the rest of the brain. So the prefrontal cortex, the midbrain, all of that, the development of that area is predicated on the ability of the brainstem to actually grow in the cerebellum, to actually develop and grow and make communication lines in that first year of life. The most influential perpetual programming of the subconscious mind occurs from birth through 6. And why we say that is because by age 6, your nervous system starts to integrate. So we've laid down the foundation, first 2 years of life, and then by age 6 and up to age 10, when the intercommunication neurons start to form, we're actually laying down how that nervous system is going to adapt and function as an adult nervous system. We're laying down not only the pathways in which it works, but its developmental processes, and basically its motor and functional cortexes are all being developed at that point in time. So we're dealing at 6 years old, not with an emotionally, but with almost a functionally adult type of brain, whether it be lateralization, and we know what we talk about when we're talking about airway development and we talk about palate development. We're going to see that it's in that period of time before the intermaxillary suture and the palatine sutures really fuse all the way, when we have the most or the greatest propensity to make changes not only in the structure but in the function of how kids breathe, how they talk, how they chew, all those type of things that are dependent on proper palate formation. So with the brain in those first 2 years and even of life, what we're seeing is a brain that is taking inputs in much more than it's taking output. It's processing information. It's taking all this information. It's learning things. So when we talk about things like developmental profiles, simple things when we're talking about children who have had difficulty nursing, that's a lot to do with how their tongue develops, how the palate develops, how they're able to pronounce things, speech patterns, all those types of things. And we're going to talk a little bit later about that affects overall neurological and emotional development. But around age 6, as we just mentioned a moment ago, it's when the child what we call becomes EEG conscious. And what I'm talking about that is brainwave patterns change as we get older. And as those patterns change, we need more of our raw materials to keep those patterns functioning. So if you look at this pattern of, let's say, frequency and brain age activity, think of it about running a marathon. When you start out in the delta phase, which is, again, the sleeping low-level consciousness, you're starting your training regime. And as you move through the process, when you hit around that, with this period, it's 12 years of age, when you hit that beta state, what you're using is a lot more energy to maintain that level of training. And then when we get to that gamma state, what we're talking about is being able to run the marathon. And how I'm comparing that is as children's brains develop, if their training preferences or their thresholds are damaged or don't work correctly, then they're not going to be able to achieve those higher levels. And what happens is when they get into environments where they have to function at higher levels, the system tends to break down. They may get diagnosed with things like ADD or ADHD or sensory proprioceptive issues. And basically what that is a nervous system that wasn't able to function at these levels because of the underlying structural, functional, and neurological implications that they had to compensate for as they got older. So any damage prior to the preliminary development of these nervous system functions cause compensatory patterns to be learned or to occur naturally to allow us to interact with our environment. So what we find often with kids or even adults that start to have thresholds is, let's take something like snoring. All of a sudden, a person starts to snore a lot. What is happening is they're starting to lose their airway when they sleep at night. Maybe the temporal mandibular joint has been damaged, and as they sleep, the jaw, the mandible pulls backwards and closes off their airway. They've had improper tongue development. They've gained a lot of weight. They have more fatty tissue. There's all these other factors that have created the compensatory pattern that all of a sudden the system breaks down and they start to snore or they have sleep apnea. And it's not that one particular issue. It's because the underlying compensations were basically adapting until they got to the point where they couldn't adapt anymore. So the rapid pace of structural brain development and development of wide range of cognitive and motor function sets the baseline and time frame for future developmental potential. And that's what I'm talking about. That's why we focus so much in pediatrics and so much in working with kids, is because we want to develop a strong base. We want to develop a functional potential and a mechanical and structural potential from which the child can adapt and depend on for the rest of their life and increase a bigger threshold for their adaptive responses. And it happens in the first 2 years very strongly, and by age 6, we've really laid down a foundation for the nervous system. If you look here, in year 1, we're creating 1,000 to 100,000 synapses. The brain grows 2.5 to 3 times its birth size. The total volume of the brain increases 101% in year 1, 15% in year 2. The cerebellum, that mainframe computer, goes 240% in the first year. By age 2, 80 to 90% of the adult volume, especially gray matter, is laid down. By age 6, 90% of their motor and sensory integration has been set up. And then at age 10, full myelination and all the intercommunication neurons are set up. So we're looking at this period of time where we're really trying to set up the parameters. And those of you in the field that working with airway issues, whether it be working with orthodontics or working with myofunctional therapists or working with any of those type of issues, we're trying to help increase structure and function. We can see that this period of time is so, so crucial. And the other thing we look at, the other thing that's important, is postural development. We're talking about two curves, primary and secondary curves in the spine. When you're born, you have one particular curve. It's your primary curve. It's this bent over C-shaped curve. As the child starts to develop, as they start to hold their head up, as they start to sit, and as they start to crawl, and then as they start to walk, these secondary curves start to come in. As they can begin to tummy time and hold their head up, we get the first secondary curve, the cervical spine. Then as they start to sit, we start to develop that lumbar spine. Of course, that it continues through crawling and standing. The secondary curves are actually what adapt the way the child functions under gravitational stresses. So gravitational forces, depending on how those curves form, change the way those bones remodel. So for example, especially in this day and age, when we have kids who are always looking down on phones or computers, they start to lose that normal cervical curve. They create this forward head posture, and we'll talk about how much that affects the kinematic chain, temporomandibular joint, and also the palate, and of course the airway. So what happens is it is actually changes in gravitational stresses, forward head posture, posterior mandibles, rotation of the cervical spine, abnormal postural gradients create bone remodeling in a negative way. Because what happens is as a bone compresses, if there's too much pressure on a bone, it creates a negative piezoelectric charge. And that negative charge, because calcium is a positive ion, will repel calcium ions. Where on the other side, where there's tension or stretching in the bone, for example, let's say in a scoliosis where you have a concavity and a convexity, you get abnormal electromechanical charges and you get abnormal bone deposition. That also happens in joints like the temporomandibular joint or in the palate if you have a distortion in the palate, or you have a child that's basically sucking on the palate and they can seal better on one side than the other. They're going to create abnormal gravitational stresses in the palate and actually cause abnormal bone remodeling. So bone tissue is constantly undergoing remodeling based on its bony matrix and also depending on its position and gravity. I'm going to talk a little bit more about forward head posture and how that affects temporomandibular joint and of course therefore affects the airway. So the things that we see in our practice as chiropractors are the stresses that start the process. Birth trauma, whether it be C-section delivery, forceps delivery, vacuum delivery, abnormal presentations, tethered oral tissues. The other thing, it's a big thing, is the birth process itself. How much time does that child spend in transition? I brought my little friend here. This is my little 4-month-old cranium. I don't know how well you can see it with this, but you can see, and you all know about sutures and fontanelles. The whole idea of this suture and fontanelle system is that as the baby goes down the birth canal, this system compresses. And when that system compresses, it actually starts what we call the primary respiratory mechanism. It compresses, and as the child exits the birth canal, it starts to expand within the first 7 to 10 days. The head should take a normal shape. And that expansion creates a balance in the dural system and also then creates balance in the flow of cerebrospinal fluid through the ventricles, which we will address a little bit in a second. So the birth process is the starting point where we can actually start to see these distortion patterns. We're looking at several things in chiropractic. We don't really look at, especially in pediatrics, at as much as bone tension. What we're looking at is dural tension. We're looking at the effect of the dural system on bone growth mechanics, on movement of cerebrospinal fluid, and on developmental profiles. So, for example, the spinal dura attaches all the way down from the coccyx to the filum terminale, comes up the entire spine, attaches, the dural system attaches to every single vertebrae as it exits between the vertebral bodies. Then it comes into the foramen magnum, our friend over here, and then it comes up into the cranium, forms the falx cerebri, the tentorium cerebelli, and it helps suspend the brain in that tissue. So the system is completely interrelated. And the two layers of cranial dura, there's what we call a meningulator and a periosteolator. The periosteolator is the one that forms the reciprocal membranes inside the brain. And what we're looking at with this tissue is we're looking at a system here that helps suspend the brain. It also allows for movement of cerebral spinal fluid. And also because it corrects to the dural, the inner periosteum of the membranes, it actually has a lot of function in the way the cranium itself grows. If it's too tight or too loose, it can affect cranial bone remodeling, both on pressure from actually literally tension on the bone itself, and also what we just talked about a moment ago, creating a piezoelectric effect by abnormal pressure gradients on those bones. And so we're looking at a system that's completely integrated. Right here, if you look at this picture, here's our occiput, here's our atlas vertebrae. This right here is the spheno-basilar junction, which we're going to talk about in a minute. And this is the layers of matter. We have a dura mater, and we have the arachnoid matter, and we have the pia mater, 3 layers. And within that space is a subarachnoid space, and that is where cerebral spinal fluid flows. So pressure gradients within the dural meningeal system, both tension on the bones and pressure gradients within the cerebral spinal system, affect bone growth. They also affect neurological function because the epineuron of the nerve attaches directly to the dura. If the dura is too tight, it can cause traction on the nerve. That traction on nerves could impede the way that nerve functions. So the thing that we also tend to look at, and what's so important, and when we're looking at palate development, cranial development, jaw development, is the transverse fascial planes. It is a whole transverse fascial plane system, and we're going to look at it here as it comes all the way through. So this is the cervical. One of the transverse fascial planes is caused by the upper cervical musculature. And this fascia connects into the ligament nuchae and the rectus capitis. So this is basically C2, this area right here. Every time you open and close your mouth, the muscular tension or the muscular balance is actually reflected back into the second cervical vertebrae. So changes in head posture, whether it be rotational things like torticollis, forward head posture, extension, it all affects this C2 area. And every time you open and close your mouth, there's a kinematic chain that focuses with that tension in this particular area, which acts as a transverse fascial plane in the cervical spine. So when we look at the body, we see these transverse fascial planes. We have the tentorium over here in the cranium. We have the one we just talked about, the cervical atlas axis and the rectus capitis muscles. We have our thoracic outlet over here. We have our diaphragm. We have our pelvic fascial plane, our knee, and then down over here, we have the plantar fascia tendon. All these these transverse fascial plane are dependent on each other. Then, of course, the other one that we want to talk about is in the root, in the floor of the mouth, where we have our tongue, our frenulum, and this area here, which helps deal with the temporomandibular joint. And again, we're going to be a little bit more specific about that in a minute. But these transverse fascial planes are all interrelated as well, because the fascia not only is transverse, it also runs longitudinally through the body. And the longitudinally fascial planes and the transverse fascial planes are intimately related with each other. So, chiropractic care. What we're looking for here in chiropractic care is the primary subluxation. We're looking for that initial issue, subluxation, imbalance, whatever you want to call it, that has affected what we call the primary respiratory mechanism. The primary respiratory mechanism is the ability of the sacrum and the occiput to move in reciprocal motion to maintain proper tension in the dural meningeal system and allow for the movement of cerebral spinal fluid and proper tension in the spine and the cranium. So this primary subluxation can occur in several places. Often it occurs right at the base of the brainstem between C1 and occiput, or C1 and C2, which is one of the most vulnerable areas in the pediatric spine. And occasionally it can also affect what we call the boot mechanism in the sacrum. In the sacrum, there are 2 places that we look at. We look at the anterior synovial joint of the sacrum, and we look at the posterior aspect, which is a weight-bearing aspect. That anterior boot mechanism is the thing that gives the sacral motion, or what we call sacral nutation. So subluxation of the atlas area creates dural tension that can cause a descending pattern, and that creates stress on the dural meningeal system in a descending manner. And also there can be a subluxation or distortion in the sacroiliac joint and the ability of the sacrum to move, and that creates what we call an ascending subluxation pattern. What's really important to understand is that these affect a global issue. In other words, a sacroiliac imbalance, when the child can't bear weight normally on the sacroiliac, they're going to throw their carriage of the weight-bearing mechanism forward, which is going to create things like a forward head posture. Okay, same thing when atlas or axis is subluxated and the base of the brainstem is being irritated, or the visual cortex is being involved because of the fact that the visual cortex is located in the occipital lobe, the baby will then, or the child will start to create an abnormal writing reflex, maybe with a head tilt, maybe with a forward posture. And then these eventually start to affect jaw position, jaw motion, and their ability basically, especially things like the vagus nerve, which gets irritated and affects the soft palate, their ability to actually suck, to draw in air, to breathe normally, and it will eventually affect palate palate formation. So when the cervical spine is not it's in balance, it sends descending writing modifications to the lower spine. When the lumbosacral spine is not in balance, it sends ascending writing modifications. And basically, writing modifications are compensatory patterns so that the body can bear weight as best as possible. It is trying to make compensations and changes throughout the time. So here we're looking at our forward head posture. And of course, again, forward head posture. This is an increased lordotic cervical curve sometimes occurs because one of the jobs of the spine is to hold the head over the tailbone. If I create a forward head posture here, you're not going to start to lean forward. What's going to happen is the lumbar spine is going to compensate and create an increased lordotic curve to try and bring the head back over the tailbone. So these compensatory patterns are so the body can balance itself in gravity. And of course, in the temporomandibular joint, what we have is increased dental stress that affects the TMJ, can cause a summation of, like we said, musculotraction. It's C2. And what happens is this C2 suboccipital tension will tend to cause that forward head posture. And that forward head posture, as the head comes forward, will start to put tension on the muscles in the neck, which will affect up around with a kinematic chain, which we're going to talk about in a second. That will affect the temporalis, the masseter, and the buccinator. And then, of course, that will affect the position of the jaw. So these are the longitudinal fascial planes that I talked about a moment ago. I'm just going to move through this for a minute. But again, we're looking at compensatory patterns here that work their way all the way up. Remember, as I said, the base underneath the palate, that is also a transverse fascial plane. So we have our tentorium here, we have our cervical one here, and if you can see, the cervical fascial plane is kind of in line with the fascial plane of the base of the mouth or of the mandible. And so you can see distortion patterns, whether it be lateral A to P, will start to cause a shift in that fascial plane. And if you think about it, every time you open and close your mouth, I don't know, 2,500, 3,000 times a day, baby's nursing, if there's a shift in this fascial plane, there's going to cause an imbalance in the way that, let's say, they can nurse better on one breast compared to the other, or they have one palate side is higher than the other. And what's going to happen is every time they open and close their mouth, they're going to create a torsion. And that torsion is going to affect the maxilla, it's going to affect that intermaxillary suture, and it's going to affect the way that intermaxillary suture and another suture that's very important, the sphenomaxillary suture, and it's going to create the inability of the palate to form correctly. Just to look, we're going to cover that in a minute. We're going to look at those sutures and what we're talking about in 1 second. So damage and irritation to these ligaments often lead to postural compensations, including the forward head posture and changes in the cervical lordation. This is the kinematic chain I'm talking about. So we have our hyoid, which we know is the only bone that does not articulate with any other bones. We have our hyoid bone sitting in the middle of our throat. We have our mandible. We have the stylohyoid ligaments that help support the hyoid bone. We have the SCM. We have the anterior scalenes, we have our shoulder girder. So this is a kinematic chain that has to stay in balance. Abnormal tension in these will affect, and again, you can see here, we're looking at the SCM, we're looking at the anterior scalenes, we look at the omohyoid. This entire kinematic chain ideally has to work smoothly. And in the pediatric practice, we see things like nursing issues, reflux issues, ear infections, all those things are signs of craniofacial distortion patterns that are showing us that the craniofacial system, whether it be all the way back into the eustachian tubes, into the sinuses, into the palate, or into the upper cervical spine or the upper thoracic spine, are not functioning normally. And these will all affect the baby's ability to create a normal functional airway. When there is disruption in the system, it affects the dural system. And the dural system directly affects the proprioceptive system in the body, and this immediately changes posture. For example, we have babies who are brought into the office sometimes, and they hate tummy time. And every time you lay them on their belly, they extend back, and they're constantly extending back or in a fight or flight state. Often that's because that dural system is too tight. It's causing too much tension, and they're literally trying to bring their head closer to the tailbone to release tension in that dural system. So when these proprioceptive systems are overloaded, also due to TMJ or TMD or cervical dysfunction, then postural dysfunction limits the ability for this child to adapt to stressors in their environment. So they start to become hypersensitive. Okay, it affects the entire nervous system. That nervous system is hypersensitive. It's in a compensatory state. These kids are in what we call a fight or flight state. And why it's so important to create normal function are simply these reasons. Facial development, orthodontic concerns. 50 to 70% of children in the U.S. will wear braces, have some sort of dental appliance. Chronic inflammation and immune issues occur because open mouth posture encourages mouth breathing, which bypasses natural filtering, humidifying, pressurizing benefits of nasal breathing. Not only does it help lung health by providing small amounts of bacterial nitrous oxide, but a huge component of the immune system. Also, mouth breathing limits part of our immune defense system. Right? It creates more opportunity for inhaled allergens to occur. So when kids can't filter the system right, they will compensate and they will mouth breathe. The other thing that happens, which is really important to function, is the movement of CSF, which we talked about. Cerebral spinal fluid is the lymphatic system of the central nervous system. And basically it removes waste from the brain. So dysfunction here directly tied to airway problems, sleep disordered breathing, and craniocervical issues can reduce the amount of CSF that's available to be exchanged. Every day, 4 to 5 times, the amount of CSF in your central nervous system is exchanged. Also, as you breathe more deeply, you actually allow for more CSF to be exchanged from the blood-brain barrier through the ventricles into the lymphatic system. So poor sleep, mouth breathing, decreased breathing, airway obstruction, cranial upper cervical issues, all these create a toxicity level that occurs in the brain, which also creates an inflammatory response, and that also reduces deep restorative breathing. It doesn't trigger the parasympathetic nervous system as well, and we have kids, therefore, that stay or work in a sympathetic dominant state. So it's really important that we be able to create this normal function. It also has an impact on behavior. Interfered sleep patterns increase that sympathetic response that we just talked about. And on the opposite end, nasal breathing has improved autonomic response. So we have kids with their dysregulated. It's very common in our practices, especially in chiropractic these days, to see kids who are considered neurodiverse, and what they really are is hypersensitive to their environment. And symptoms that we see is ADHD, bruxism. Little kids, I hear moms say that they hear their kids, grinding their teeth at night. All right, this is all stresses that occurred. Things like enuresis. All these are the inability of the parasympathetic nervous system to kick in when the child's at night. And part of the parasympathetic system is triggered by oxygen level in the brain as well. So we talked about a moment ago, I'm not going to spend a lot of time with this with you guys, but as chiropractors, we're looking to see if the pattern is an ascending pattern coming from the pelvis up, creating these distortions, or is it a descending pattern? So, these days we see a lot of tethered oral tissue cases. Tongue tie is really common, or is much more common than it used to be. And we have to determine if that tongue tie is causing a functional issue, or if it's causing a compensatory issue, or if it should be left alone. In some cases, it should be left alone. In some cases, it should be cut. But that will depend on if we're having a primary ascending pattern coming up from the pelvis that's causing the imbalance in that transverse osseous plane, or we're having a descending pattern and the trigger is coming from either the cranium, the jaw, or the upper cervical spine. All these considerations where, as chiropractors, we must take into effect. And what we're looking at, things like functioning of the visual cortex, we're looking at proprioceptive and nociceptive input, we're looking at neurological input. So we're trying to get a global picture, because what we really want is a baseline to come from. In other words, we're looking at this child's neurological developmental profile, we're looking how their system is integrated, and we want to track that integration. So when we refer out, for example, to anything from a myofunctional therapist to an orthodontist, possibly from maybe a palate spreader or an appliance or braces, depending on the age of the kid. What we're really looking for is, if we're using that ancillary protocol, is it making a positive change in all of these factors? Not just in the position, but actually in the function and the neurology behind it, the integration of the nervous system. It's really important. I've seen this, I've been practicing for 44 years, that in some cases, an appliance or palate spread or something will be doing its job on one level, but it's causing compensatory patterns on another level that are actually worse than the initial issue. So we really need to have a baseline to understand what we're looking at and how we're affecting the nervous system. We look at all these factors in here. How are these factors functioning when we deal? So when I refer someone out for, let's say, a palate spreader because they have a really high, narrow palate, the airway's blocked, chronic sinus issues, their jaw's not working right, they can't nurse, or they're not, they have had nursing issues a long time ago, they're having feeding issues, and they need a palate spreader because functionally the palate not only is not opening, but it's causing all these downstream effects. So we want to be able to look at that at this time. The same thing when I refer somebody out or not to have a tongue tie cut is that tongue tie causing that baby inability to nurse right? Is it not sealing against the palate, not allowing the palate to form correctly? We have to take in more than one factor when we're looking at these processes. So descending patterns come from the upper cervical occipital areas and the cranium and TMJ. They are basically in that suboccipital region. And what's really important and why I want you to look, and I use this study a lot, is that if these systems break down in the suboccipital area, we talked about that C2 area, the occiput, that whole area. If these systems break down, what happens is there's a reduced capacity to absorb stress later in life. So that's why we're looking at kids who start to get diagnosed with either being on the spectrum, being neurodivergent, having sensory proprioceptive, sensory integrated disorders, ADHD, whatever the issues are, it tends to be diagnosed at anywhere from 3, 4 to 5 years of age, because what happens is they have a reduced capacity from the primary issue that was left untreated, and they have a reduced capacity to deal with stress later, and it comes up as a disease process. So are the patterns coming from the top downwards or from the bottom up? And one of the things that we look at, of course, here is the spinal-basal mechanism. We look at the position of the occiput and its relationship to the ability of the spinal-basal mechanism, which I'm going to talk about in a minute. The spinal-basal synchondrosis is the first area of the cranium to reach adult size, but it doesn't fuse, it doesn't become less than a synchondrosis joint for about somewhere between 20 to 26 years. And what the synchondrosis joint is, we're talking about this area right here between the purple and yellow area. It is the sphenoid bone articulates with 12 bones, 4 single, the vomer, the ethmoid, basically the entire cranium, except for the nasal, the lacrimal, and the inferior nasal concha. So the entire craniofacial structure is often dependent on the ability of this spinal-basal mechanism to move. The other thing that the spinal-basal mechanism moves is it works with a suture that I talked about a little while ago, is the sphenomaxillary suture. So it's the relationship of the pterygoid process of the sphenoid wing, the palatine bone, and the maxilla. And this allows for the palate to expand and contract normally. If this sphenomaxillary suture is restricted and jammed, the palate can't expand laterally. So we want to look at this when evaluating the cranium, when we look at this sphenomaxillary suture. So I want you to just give you a little picture here to get an idea of how this works. During respiratory mechanics, when you breathe in and out, or when a child sucks, or basically the secondary respiratory mechanism, diaphragmatic motion is moving, this is the spinal-basal junction right here. Every time you breathe in, it rises slightly up, and you can see how it pulls the palate at the same time. So the palate will come up a little bit in the posterior aspect, the palatine bones, and then come back down. This is the falx cerebri I talked about earlier. This is the tentorium. So the movement of the spinal-basal changes tension within the system. At the same time it changes tension, it allows for the flow of cerebral spinal fluid through the subarachnoid space. But I really want you to get an idea of how this craniofacial development and structure is strongly dependent on the ability of this spinal-basal mechanism to work correctly. And for that to happen, this is an underneath look of looking at it. So we're dealing with the spinal-basal junction here. This is the palate that we just talked about. And again, we come here. This is the sphenomaxillary suture is over in this point right here where I'm pointing over in this area. This entire dynamics are dependent on craniofacial development, also affect palate development. Remember, we know the palate is formed from 4 bones, 2 maxilla, 2 maxilla, and 2 palatine, and we have all these sutures involved. They fuse at different ages. Matter of fact, there's been studies that say in females, the intermaxillary suture and this cruciate suture doesn't completely fuse to around age 11, and sometimes in boys, somewhere between 13 and 14 years of age. So when we're looking at the way the palate is developing and we're looking at deciding what we should do, how do we treat it, that sometimes putting appliance in too soon when the growth centers haven't completely healed yet may be an issue, or waiting too long may make it a longer term process. So we have to start to measure and develop that. We talked a little bit about descending, ascending patterns are more focused on chiropractic. We're talking about pelvic stability and the ability of the weight bearing mechanism to allow the head to come into a normal position. As we showed earlier, when the sacroiliac joint is out of balance, it's going to throw the head forward, taking that weight bearing mechanism forward, creating forward head posture, which will then reflect in those transverse fascial planes, longitudinal fascial planes, and the ability of the jaw to work correctly. This is that sacroiliac joint that we're talking about here. It's a ligamentous joint. This is the weight-bearing part of the sacroiliac joint. And if this area compensates, what we see is compensations going all the way up from the latissimus dorsi to the trapezius. You can see how the trapezius muscle here attaches to the cranium, and you can see these muscle triangulation patterns, so chronic tension patterns, and of course, when muscles pull on bones abnormally, that creates a piezoelectric effect. That also changes the way the bones remodel. But underneath this is the fascia, which also attaches to the dural system, and therefore we get changes in the dural meningeal system at the same time. But this is what we're looking at. We look at pelvic instability. These large muscle groups, latissimus dorsi, trapezius, are balanced muscles within the system. So in our sacroiliac joint dysfunction, we create these compensatory patterns. But I want to focus more up on further moving up into the cranium and what we as chiropractors do. So the cranial bones in our world have some specific functions when we're dealing with airway development and when we're talking also about postural development and palate development. So the temporal bones articulate directly with the temporomandibular joint. And with abnormal TMJ motion, disc deflation, condyle misalignment, temporal imbalance also is the bone movement. Now, how does it do that? Well, if we have our mandible, I lost my mandible. I'm sorry. We have our mandible, which sits here. I'll have to use the baby spine. Oh, here it is. I got it. So we have our mandible. And what happens is the condyle of the mandible sits into the temporal fossa. If the temporal bone is what we call externally rotated or pulled back due to the abnormal tension, let's say through the temporalis, it pulls it back. It pulls the condyle of the mandible posterior. In other words, it creates a deep bite. If the temporal bone rotates or moves slightly anterior, pushes forward, it pushes the condyle of the mandible anterior and causes the jaw to move forward. So, for example, if the temporal bones rotate or cause abnormal tension this way, it can pull the condyle, the temporal fossa up, and it pulls the condyle of the mandible up, and it pulls the jaw back and posterior. And this can not only distort the vestibular system, but distort the ability of the mandible to come forward. It also will affect the trigeminal nerve, and that creates dysregulation in the trigeminal nerve. The other thing that we look at, of course, is the balance mechanism that we said through the visual cortex. So if you have TMJ dysfunction, if the mandible for itself is the causative factor, if I take my mandible and push it posterior, this is what it's going to do to my head. As I push the mandible posterior, it's going to rotate the temporal bones, and it's going to pull a forward head posture, and it's going to hold my jaw in this position and my head in this position. It's going to change the visual proprioceptive writing reflex as well. And what it's going to do is it's going to affect the base of the brainstem. So what we're talking about is traction in the dural system affecting the cerebellum, and it could cause things like gross motor issues, milestone development, abnormal milestone development, retained primal reflexes, difficulty processing information because it affects that brainstem and the cerebellum by putting traction on the dural meningeal system. So proper development requires integration of the vestibular system, visual proprioceptive system, the motor system, and TMJ dysfunction. I guess the point of all of this, that I know I'm putting in a lot of information, I guess what I'm trying to do is get you to understand how important the work that we do and the work that you do is to the overall development, that it's not isolated, that nothing in nature happens in isolation, that everything we do has a global effect. And that's really what's important. When we think about what we're doing and how we're working, it's really important for us to get an idea or get a big picture. That's why I think very often it's important to co-treat. because this way we all have a different view of what's happening and what we're looking at. And I think it's really important to be able to do that to help support normal growth. I'm not going to talk much, just because of time, about TMJ, modifications or classifications, but we always talk about, 3 classes, 1, 2, and 3. The class 2 is the one that we often see with a problem. The class 2 is where you have the posterior mandible. That is the one that tends to affect the airway worse, because as the patient, whether it be a child or adult, lies down and goes to sleep and the jaw muscles relax and the mandible falls back more posterior, it tends to cut off the pharynx a little bit. What we look at when we look at TMJ and palate development is we look at the ability of the jaw to go through 3 phases. The occlusive phase, like how is it balanced when it's closed? The rotational phase, how does it start to move when it opens halfway? And then translational phase, how does it move when it opens all the way? We're looking to see that the jaw tracks equally and moves balanced, because again, if the jaw deviates, especially when it's opening and closing, it's going to start to pull on the musculature. It start to create craniofacial abnormal dynamics, and it'll work all the way through, especially if it affects the sphenoid wing that we just showed you a moment ago. It's going to affect that sphenomaxillary suture, and it's going to directly affect the ability of the palate to grow correctly, especially if that sphenomaxillary suture is an issue. These are the muscles that we're looking at here. I don't have to show you the pretty videos here, but I want you to look. These are the pterygoids, lateral pterygoids. That's what we're looking at. This is the condyle of the mandible that I just mentioned a minute ago. This is the temporal fossa that I wanted you to take a look at and see right here. This is the motion that we're looking for. So we have occlusion, rotation, and then translation. All these mechanics have to fall in line for things to work normally. I'm going to pass through this one, though. We're going to look, again, forward position of the mandible, all again in relationship to the temporalis muscle, position of the temporal bone, our mastoid process. Here is our digastric muscle. So we're looking at this entire system as it affects bone growth. And again, in pediatrics, why it's so important is because when we look at the pediatric skull, we have all these sutures and we have these fontanelles of growth plates. The first year of life and even up into the second year of life, the cranium is not really a protective mechanism. What it is, it's designed to help allow the brain and the systems to develop normally. It's about growth. It's about expansion. The brain's going to double in size. The systems are going to change. The nervous system is going to create 80 to 90% of its internal processes. So it's so important that we get this normal function, this kinematic chain works correctly, that we get balance in the musculature, that we then can affect normal growth patterns in the palate. Let me just come through this for a minute because I know we're running in time. These are just kind of summarizing what I've talked about. That cranial motion affects TMJ, temporal bone affects the position of the jaw and occlusion, frontal bone will affect the motion of the jaw. We're looking at symmetry. We're looking at facial symmetry, and we evaluate. We want to see if structure and function are coordinated. All right, we're looking at palate, facial symmetry, TMJ balance shows up as an uneven orbit size, ear height, asymmetry, the zygomas on the maxilla. Palate and maxilla become abnormal. We have abnormal mandible motion. Remember, we're talking about the maxilla. Let me take this jaw. So we're talking about this maxilla. We're always looking at the palate, but we actually have to look here at the maxilla is also divided in half externally. So we have 2 parts to the maxilla where we're looking at the face on, and we also have this maxillary zygomatic suture. So the relationship between the maxilla and the zygoma plays a big role. The maxilla is a buffer. Every time the child opens and closes their mouth, it creates stress on the maxilla. If the jaw in this position, you can see it's deviating. If every time this child opens and closes the mouth, it's going to cause this distortion in the maxilla, and it's going to affect the way the palate fuses or the ability of the palate to fuse normally. So we look at that. We look at speech and feeding in infants. TMJ's function cause weaker asymmetric latch, poor suck, swallow coordination, and heightened gag reflex. Later, it create oral motor development and articulation issues. So we're always looking at function, and we're looking at this palate, the intermaxillary suture. We have a cruciate suture here. This is the sphenomaxillary suture. Again, a high, narrow palate is often going to create restricted mobility. It's not going to allow the tongue to sit up against the palate correctly. It's going to create abnormal breathing mechanics, it's going to have abnormal eating mechanics, like normal speech mechanics. And what happens is you're going to often get retraction of the mandible in these cases, at the same time restricting the size of the airway to be developed. So all this process is so important to look at when we're trying to develop and look at neurological considerations. So when we have these structural neurological considerations, one of the things we look at is abnormal or low tongue posture. It prevents proper development of the U-shaped palate. And why we need to work together, especially let's say if we're working with a myofunctional therapist to help create normal mechanics with the tongue, if the palate is abnormal, if the sutural system is abnormal, if the balance mechanism, the temporomandibular joint, you're going to be fighting an uphill battle. You're going to be finding a much more difficult way than if we clear out the pathway, if the nervous system is working correctly, if the palate growth patterns are normal, if the transverse fascial planes are normal, if the temporomandibular joint mechanics are normal. That's going to help to facilitate the ability to actually redirect normal tongue motion. All right, we want to look at that because it encourages so much issues, things like mouth breathing, which can see a problem, and that contributes to airway collapse during sleep. It actually sets up a protocol over time where the actually is an adaptive mechanism where the child then becomes a mouth breather to get enough oxygen in, never forms a palate right, ends up with chronic sinus issues and things like that. So again, cranial distortion patterns between the sphenoid, maxilla, temporal, and frontal bone, alter sinus and airway flow. They create neurological functional weakness, weak functional oral facial muscles. The lips don't seal, cheeks collapse inward, tongue posture drops. I mean, these are all things I know that you see all the time. And what we're looking for on a neurological level is the other factors that sometimes you don't consider. Things like retained primal reflexes, not able to reach certain milestone, cranial nerve dysfunction, inflammatory issues. We talked about that, a moment ago. Mouth breathers tend to bring in higher levels of bacteria, so it affects the immune system. And then, of course, we have behavior and developmental issues as well. So we're always looking at the effect, the overall effect of this. And again, determining ascending or descending patterns, checking that kinematic chain, looking for postural stresses, watching cranial facial growth patterns, seeing neurological development, and of course, spinal development, normal curves of the effect. I just had a little girl brought in who's been complaining of neck pain, and when I evaluated her yesterday, we had an x-ray that was taken of her from Children's Hospital. She had absolutely no cervical curve, completely lost normal cervical curve. She had a forward head posture. She had a posterior mandible. Her mom said she grinds her teeth at night. She's a mouth breather, and she's now already at age, I think she's 4, has chronic neck problems. So we're looking at the effect of the TMJ, the craniofacial development on normal mechanics, both spinal and growth patterns. Just the last thing I want to do here before I go back and ask you any questions, I want you to kind of take a look. So the pediatric cranium is a membranous system. And what you're looking at here is this is the dural meningeal system, as we talked about, attaching to the cranium, and this is the sutural system. It is constantly expanding contraction as the child brain is growing, and that is predicated on the normal functional capacity of the sutural system, the nervous system, and the ability of the child to actually create normal function within the jaw, the palate, the cranial system, and the dural meningeal system all the way down. So when we're looking at a pediatric skull, we're looking at a very pliable system that we really want to set up a positive baseline so that they don't create developmental issues later on. What we do, our treatment protocols are based on correcting the causative pattern instead of attempting to deal with the overlying compensatory patterns. In this manner, once we get into those causative patterns, it is a very effective approach, and it increases the percentage of successful treatment, while at the same time reduce the negative rebound side effects of less specific treatment protocols. In other words, it also helps when we are coordinating and working with other practitioners to help their work become much easier. I talked about this role, so we're going to leave it at that. I appreciate you taking your time to spend with me. I hope I gave you some information that was helpful to you. We do have some case studies that we can also share at some other point with you. The only other thing I do want to mention to you that we did about 4 years ago, my wife and I wrote a book called It's All in the Head. So I'm going to do a little promo here.
Yes. Ah,
And the whole idea behind this book is for healthcare practitioners, parents to understand the implications of craniofacial distortions when they're looking at what they could do. What's great about the is we have in every chapter a bullet list of what you can do, what to look for. When you're working with other practitioners, those of you in other fields. We have patients who buy it for other people. We have other practitioners keep it in their office. When people ask, well, why do I have to wear a palate expand? Why do I need braces? Why is it because my kid's one eye small and the other? What does it mean? It gives them an idea of what the process is, how effective, what effects it may be having. So we kind of wrote it so that we don't have to spend all this time trying to educate everybody that walks into our office every single moment in time. But again,
Wow.
you and I don't know if you have questions, if it's live, I don't even know. But if you have any questions, I'll be happy to answer them.
Oh my gosh, that was so much information. This is definitely one of those classes that I'm gonna have to go back, put it in slow motion so I
Uh,
can really gather. You shared so much right now,
I
and I am
know.
so
I
excited.
didn't know where to go.
This is incredible, incredible. Such a good webinar. Thank you so much. We do have
My
some questions
pleasure.
coming in.
Sure.
Summer is asking, what is the best way to avoid scoliosis in children?
So the best way to avoid scoliosis in children, I mean, again, I am a chiropractor, but it's looking at musculoskeletal development patterns. So first of all, you have to determine, is the scoliosis compensatory? Is it congenital? Or is it just what they call idiopathic, which is adaptive? So when you're looking at a child, not only look at the curve of the spine, but you want to look at the second cervical vertebrae and the second sacral segment. If those two areas are not over each other, then the propensity for the scoliosis to get worse is much higher. So once you get the second cervical vertebrae and the second sacral tubercle over each other, you can then create a normal adaptive response. And as the child grows, it will start to change. So the best way to do it is to basically track the child. Make sure that posture is there. Look at abnormal muscle imbalances, and as soon as you notice it, don't wait for the pediatrician or somebody. As soon as you notice it, the earlier I've treated kids with scoliosis at age 2.5. I've treated kids that
Wow.
shown them, with hemivertebrae congenital scoliosis. So the sooner you get on top of it, the quicker you can make a more permanent change. Because during that period of time, the bones will remodel positively, and that's what changes the scoliosis. It's not changing the muscle balance;
Mhm.
it's changing the gravitational stresses, so that when they keep growing, the bones remodel positively. That's why it's much harder to change a scoliosis in like a 30-year-old than it is in a 5-year-old. So I mean, that's
Amazing.
kind of what we look for. Yep.
Do you have any advice for someone experiencing tinnitus?
Yeah, it's a tough one. It depends how old the person is, how long it's been there. So tinnitus, and I've treated a lot of people with tinnitus. My experience, and this is my personal experience, if it's an older person and they've had the tinnitus for more than 2 to 5 years, it's very difficult. The sooner we get to it, the easier it is, because usually with tinnitus is there's some kind of damage to the nerve as well. And once the nerve gets damaged, it's slow to deal with. But almost always tinnitus, I find, and what we find is that it's affected by the mechanics of the temporomandibular joint, the temporal bone, and the sphenoid, and that relationship. They can cause
Mm.
compression on the nerves, and that's what you get from the ringing. One of the ways that we test if I'm going to be able to help them, is I have the patient bite, I have them listen to the tinnitus and have them bite down fairly hard and then relax. If the pitch changes at all when they bite, then there's a good chance that we can help them, that the mechanics are still functional enough to change it. If there's no change, it just means it's usually harder to change because the nerve is already adapted and there's not a lot of space to change. But if they bite and we get a change in that pitch, then there's a good chance that I can help them with it. But cranial work is really important to help balance the tinnitus and deal with eventually the midbrain, middle ear area.
Do they bite on their own teeth?
Yes, I have them bite
Clench?
on their own
Okay,
teeth.
not on
And
teeth.
if they
Okay.
can't, if it's uncomfortable, you can put like a tongue depressor or something in
Mm-hmm.
it. The idea is to create compression forces here. That's what you really want
Right.
it. If those compression forces change the pitch or the tone or the sound, any change in it, that's a good sign. And that means I have a better chance of being able to help them with it.
Amazing. How do dural relationships and tension patterns affect growth, regulation, and function in infants and young children?
Okay, so it's actually the primary thing that affects those problems. So durum and injury. So kids don't have bones that move out of place. So think about it. You have a 4-month-old. How is a vertebrae fixated in a 4-month-old. There's no ankylosing, there's no exostosis, there's no degeneration. So the dura attaches inside. So when there's trauma and the dura gets torqued or gets twisted in some way, it creates a kind of almost like a reflex pattern. And that tension in the dura is affected directly on the attachment to the bone. So it locks the bone, normal kinesiological movement. It affects the epinerve nerve. So it pulls and tractions the nerve. So it changes that nerve's ability to transmit impulses, and it changes tension in the system. So how I explain it is simply this. If you play a string instrument, guitar or violin, if you turn the tuning fork on the top and attaches to the fretboard, you change the tone of that tune, right? You change the tone of that string. Well, the same thing happens in the dura. If I torque the dura, if the dura gets too tight, it changes the tone of the dura. So it creates tightness in the dural system, creates tightness in the fascial system, and it causes traction on the nerve. So one of the things that causes nerves to not fire correctly in pediatric practice is actually traction. There's a book called Adverse Mechanical Tension of the Central Nervous System written by Alf Brigg. And he says that traction on the nerve actually changes the nerve's ability to transmit impulses. So dural attachments, so let's say a child comes out, I just had a little baby that was born and came out. Transition was only, mom said, was less than 8 minutes. The baby literally just shot out of her body. And when we took the baby and held the baby, it literally looked like the baby's sacrum was rotated one way and the head was rotated the other. And it was like it just torqued, it corkscrewed out of the mom's birth canal. And that corkscrewing created this abnormal tension. So the baby would only turn their head easily to one side, wasn't able to nurse well, and was spent a lot of the day crying, didn't sleep well because of that abnormal tension. So that's what we actually look for in pediatric practice is tone in the dural meningeal system and where those attachment points are either too tight or too loose. And then what we do is try and release those tension points and restore normal balance to the dura.
Amazing. I have so many more questions. However, I would love to invite you back.
Okay.
Yeah, somebody else said, thank you, thank you. Agreed. We'll come back to this lecture over and over. We need part 2 to focus on airway. So how
Okay.
about we schedule another one for
Yeah,
you
we
to
do.
come
Let me
back?
know. We'll be traveling for the next for the next month or two, but maybe towards
Perfect.
like
After
June
the
or something like that.
summer.
Yeah, or after the summer. That'd be
Yeah, we'll do
awesome.
it after the summer. That's
I'd
what we're
love to.
scheduling for right now.
All right.
Well, thank you so
All right.
much. This has been a wonderful hour. I
Okay.
cannot wait to go back and listen to this. And by the way, if you're an Area Circle member, we do have summaries of our lectures that are uploaded underneath the lecture. So if you're a
Awesome.
person who likes to read, join us over there so you can get the summary
Okay.
of the
And,
lectures.
and
Let's see
if you
what
want
else
to
is going
contact
on.
us, just go to
Yes,
drmartinrosen.com, drmartinrosen.com. That's my website, and just add Gmail to that instead of takeoff.com, and that's my email. So, if you want to contact us or have any questions or purchase the book, that's the place to do it.
perfect. All right. Thank you for sharing that,
All
guys.
right.
Have a wonderful night. Thank
All
you
right.
so much. We'll see you next week.
Thank you. Bye-bye. Take care.
Bye.